Well, welcome everybody. My name is Linda, and I want to invite you to join me for a coffee as we just sit down and relax this morning. I hope that you'll help me welcome my special guest, Sandra Wallace, as she shares with us today. I know you're going to be inspired by her story. So, Sandra, you shared with me earlier that your story revolves around OCD. Um, what does for everyone, what does OCD actually mean?
Great question, because I think that word gets used interchangeably with other things, and people will say, "Oh, I have OCD," or "I'm a little bit OCD." In order to be diagnosed professionally by a clinical psychiatrist or a therapist, we have to follow the guidelines of the Diagnostic Statistics Manual 5, which is like our psychiatric Bible. And part of assessing someone for OCD is they have to have two things happening. They have to have obsessions, which are unwanted, intrusive impulses or urges, and they have to have compulsions, which are like behaviors, whether they're mental behaviors, mental acts, or outward acts that are intended to help bring down the anxiety as it relates to the obsession. It also has to involve at least a minimum of 1 hour a day that you're obsessing about things, which really is not a long time when you think of it. I have clients that obsess anywhere from 6 to 8 to 9 hours a day with their obsessions. So those are two of the main things that in order to be diagnosed, and it can't be related to some other disorder like substance induced or any other kind of physical ailments. So those are some of the criteria.
Okay, so Sandra, you come with a nursing background?
Yes, yeah. I was a psych nurse. I trained in 1994. I went back to school at the age of 27, and I attended the psych diploma program out of Brandon, which is where you are, Linda. And I lived there for 2.5 years. And upon graduation, then I was able to practice as a registered psych nurse.
Okay. So do you find that OCD is connected to anxiety, fear, stress, that type of thing?
Yes, stress isn't going to, stress will bring on the OCD, but OCD often is, we've got a few different predispositions, a few risk factors to develop OCD, one being a predisposition to it. So whether our parents or genetically, whether it's our parents had OCD or maybe a generation before had it.
So it is hereditary.
Yeah, it can be. There's studies
Oh,
show that it can be hereditary. It can also be environmental. It can be a variety of different reasons people develop OCD. Often after very traumatic events, it will surface as well.
how
And
would it be
so,
environmental, Sandra?
pardon me?
How would it be environmental?
Well, if you are growing up in a dysfunctional family, I myself grew up in a dysfunctional family. And when I look back, although I wasn't diagnosed till I was 27, I actually had OCD as long as I can remember. And I remember there was times where I was doing mental acts, mental rituals, counting to a certain amount of time, praying. I grew up Roman Catholic, so I prayed 3 Our Fathers, 3 Hail Marys to cancel out my obsessions. Now, also, because I didn't have a lot of control over my environment, I allowed my OCD to take control. And what I mean by that is being able to make sure that everything would be just right. And it's interesting, as people living with OCD can appreciate that what is just right, having an obsession and doing a compulsion, that mental or outward act, doing it so many times one time versus having to do it so many times another. So for example, cleaning out the bathroom tub, I had to clean it out in a systematic way before I had a bath 3 to 4 times. But if something interrupted that ritual, that compulsion, then I would have to start all over, or I'd have to do more. And often our thoughts or obsessions are related to catastrophic things occurring. So we want to prevent catastrophic things from occurring to ourselves or others. So that's where the need for the compulsion lies, is we have to do something to neutralize that negative thought, that catastrophic thought. And it comes in the form of a compulsion. So when you mention, Linda, is anxiety and stress, absolutely. Most of our obsessions will create tremendous anxiety. And the only way to alleviate that anxiety, to bring it down, is by doing a compulsion. But what people fail to recognize is the compulsion that we do eliminates our anxiety or decreases it only temporary till that next obsession comes along. So it's that vicious cycle. I often refer to it as a clock. So if you think of the 12 o'clock position, you have an obsession. It's unwanted, intrusive. And then what does that create? We go to the 3 o'clock position, and the 3 o'clock, it produces tremendous anxiety, which leads us to the 6 o'clock. And then we have to do a compulsion, and we're back to the 9 o'clock, alleviating that anxiety brought on by the obsession. And guess what? The clock always strikes 12 again. And that whole vicious cycle repeats itself. So what I teach people to do is between the 12 and the 3 o'clock is to jump out somewhere in that halfway mark, maybe the 8 minutes after, and jump out and be able to recognize the anxiety for what it is before we have to do the compulsion.
So Sandra, do you think like I know when I go out somewhere, I'm in the car and it's like, oh, did I unplug this? And did I, and then I'll have to come back in the house and check everything. Did I blow out the candles? Did I unplug the hair straightener? Turn off the coffee pot? Did I lock the front door when I left out the back door? That stuff. So, to come in and check everything and then leave, is that a level of OCD that everybody has? Because so many people have that,
Yeah. Yes. Great question, Lyndon. I think it's two parts to that. Is it OCD? Again, it could be a mild, because we have a spectrum. We have mild, moderate, and severe. So again, we would have to do some testing. And what I do with people to do an assessment is there's lots of different tests that you can use for being able to determine if someone has OCD. It's like check boxes. So we would have to ask, get a really good overview snapshot of everything that's happening in your life, or is it more isolated to that specific, leaving the home? And what are the underlying fears that you have associated with that? Is it the fear that is it the fear that the house will burn down? Is it fear that someone's going to get hurt? And then in addition to that, how much time are you consuming on average on a daily basis worrying about it? And another thing I would ask the person is, once you get to where you're going, should you not turn back and check? Are you still ruminating? Are you still thinking about that? Does it take a lot of time? Are you consumed by it? Is there is there elevated anxiety that stays with you? There's so many factors, but again, that 1 hour mark is sort of a guideline to gauge whether it's OCD, along with other things that we have to assess. So I think the important thing is that people, if they're worried about it, then to speak to a therapist or someone trained in that field. And I think the key there is getting to work with someone who's an expert in the OCD field, because many times people come to me and they've been through 2 or 3 psychiatrists, or they've been trying to do it on their own and they've not been properly diagnosed. So they've maybe been misdiagnosed. Therefore, they've been on the wrong medication, if that's what they choose to be part of their treatment. They've been told the wrong therapy, the wrong coping skills. So it's really important that we as coaches or therapists or people working in the profession, we know what questions to ask, because people are not forthcoming with OCD. We have a lot of shame and guilt. And I know when I got diagnosed at 27, I was so relieved to put a name to it. And not a name to label myself, but a name, as I tell all my patients in the hospital, and as a coach now, I tell people not to get caught up in the diagnosis so much as it's an opportunity and a vehicle to allow us to do the right treatment and to be able to get on the right path. Because for so many of us, we've been on the wrong path for far too long.
Yeah, and there's certainly a difference between just being, multitasking and going on, automatic pilot, and then realizing like, how did I even, and that's where you just like, did I unplug something? Because you're doing four
Yes.
things at the same time. So
Yes.
there's a
Yeah.
big difference between that and how, how you're describing,
Mm-hmm.
um,
Yeah.
the repetitive behaviors.
For
So
sure. And Linda, if I could just add to that too, is often it's going to impact every aspect of our life living with OCD. So we may lose our job because we're so late. We might be coming back time and time again to check. We might be late for
okay.
work on a regular basis. I know for work with my hit and run OCD, it should take me only 15 minutes to get to work. Some days it was taking me an hour because I was retracing my route over and over. So it could impact your ability to your attendance at work. It could impact your ability to enjoy your family life, your social life, every aspect. Usually when people have OCD, it trickles into every aspect of their life to some degree.
Okay. Yeah, I hadn't thought of the transfer and how it would connect everything. Yeah.
Mm-hmm.
So is it a learned behavior?
It's a learned behavior in the sense that we learn what works for us to bring down our anxiety.
Okay.
Now, what works one time might not work the next, or we might have to up the ante. OCD is very sneaky. I always tell when I'm coaching individuals, I always tell them OCD will come in any way it can. It'll come in through the back door, the side door, through the front door, through a window, any way that it can come and disrupt our life. And so the biggest part with us living with OCD is we want 100% certainty. We want that 99.9, we're latching on for that 100%. So one of the biggest things with OCD is we have to learn to live with uncertainty. And that's probably our biggest struggle for most people, I would say, is not having that 100% certainty that everything's going to be okay. But
So
in real life, nobody has 100% certainty what's going to happen an hour from now, right?
no, no. So it's kind of a control thing then.
It is. We're trying to control our immediate environment. We're trying to control the outcomes before they even occur because we want to have that certainty. And it gives us such a sense of relief. And what's happening from a brain perspective is our neurotransmitters are firing off. So in a false sense. So it's kind of like a smoke detector going off and there's no fire. That's what our brain does. So our brain can only focus on one thing at a time. So it's that, you know how we talk about the fight or flight,
Mm-hmm.
that parasympathetic and sympathetic nervous system. So our brain tells the rest of our body that we're in a sense of danger, that we have to flee, we have to do something. So in our case, we're doing the compulsion. But I like to, there's a way I like to say it: fight, flight, or flee. Sometimes we flee the environment altogether because we don't want to deal with it. The anxiety levels are so high. So when the brain is sending these false messages, our brain is telling us to react. And in a lot of situations, it's good to have that fight or flight. But in the situation of the obsession, we have to learn to sit with that uncertainty long enough to know otherwise. So again, being able to face the fear without doing the compulsion.
So routine would help.
Routine, it depends in what context. Like routine is not something that's probably works in favor of OCD, only
Okay.
because routine, how do you define routine? If I
So that
define
could
routine,
actually feed it then. That
yeah, I
okay.
really believe when you have routine, then you know already that's a form of control, right? Because you know the routine, so you know what the outcome's gonna be. What I teach when I'm coaching individuals is I teach them to go out and do various exposures without doing any kind of compulsion, just sitting in that. But it's not all at once. What I do is I work with people, I do a technique from the 70s, which is still is the gold standard to this day, called cognitive behavior therapy. So what I teach people to do as a coach is I teach them to think of differently. disrupt the pattern in the brain of thinking a certain way, and therefore our behavior can change in response to it. And then that is therapeutic. And within that is a #1 technique called ERP, exposure response prevention. So we break down the exposure, exposing to a feared situation without doing the compulsion. So we do that on a hierarchy. Like, we don't throw you in. Let me use, for example, maybe this will, can I share an example, Linda?
Yes, sure.
Yeah, okay. So right now I have red lipstick on. That's intentional, because when I first got diagnosed with OCD, prior to getting diagnosed, I was always afraid of getting AIDS. And in nursing, I remember thinking, what if I poke myself with a needle? I automatically assumed that that person that I was giving the injection to had AIDS. So if I came across something on a desk, on a countertop, maybe it was ketchup or maybe it was a marker, I automatically assumed it was AIDS, blood, and by touching it I would get AIDS. So when I started my exposure around this main theme, because I had almost every type of OCD imaginable, when I did the exposure here, I had to just sit with a drop of ketchup on the table and just look at it. And then I would have to touch it. And then I would have to refrain from washing my hands. And then I would get into hierarchies. So what I do is I make tailor specific programs based on each person's needs. It's not a cookie cutter system. The approach is standard, but the techniques we use within them are very personal. So I create tailor-made programs for each person, and we rate an anxiety level with each obsession. And then we start to do the exposure with the lowest anxiety, and we build up like a ladder. It's kind of like building that solid foundation.
Yeah, so even changing it up, like going out the front door instead of the back door.
Yes, exactly. Yeah.
That would just,
So yeah, or even just checking, like, for example, everything in the house. I do in vivo exposure with people, real life exposure. So I'll go into their homes and we will get on Zoom and we will walk through every room in the house and determine what's the obsessions lie in that room. So in my apartment, when I started, my therapist, Dr. Vivian Rowan, actually physically came to my house and we went through every room in my house, because every room I had rituals. I had compulsions I had obsessions about the bathroom. I had to bathe in Javix and Mr. Clean. I had to put that in my bath to keep me free from dying of AIDS. I couldn't use certain towels. I had to touch the doorknob a certain way, use my sleeve, and not have direct contact with that. So every room. So when I'm coaching, I will go through the person's home and even their workplace, because things will be different in the workplace setting versus the home. So yeah, we create a tailor-made program specific to each person's needs.
so Sandra, do you think that OCD has increased in the last few years? Because we lost control over a lot of things.
Mm-hmm.
So has
Yes.
that made an impact in the group of people that you're working with?
I believe it has. Statistics still show, US statistics show 2 to 3% of the population, and a little less in Canada. But I have trouble with statistics because, and the reason I do is because a lot of statistics aren't gathered. If people see private counselors or they go for help in different realms, those numbers are not reflective in the overall statistics. So I really think the numbers, I almost want to say, when you see a number, you can almost double it, a minimum of doubling it, if not more. So yes, and I think COVID has impacted that. And whether I'm working with OCD, anxiety, or depression, I have seen an increase, because I use the same technique in all three realms. I use the same CBT with anxiety, with depression, with OCD, because it works for all three. But yes, definitely with COVID, I feel that the anxiety levels, the uncertainty, not knowing, people are having a lot more anxiety, a lot more panic attacks, and with depression. So depression and OCD and anxiety can all be kind of enmeshed together. We call it comorbidity or dual diagnosis or triple diagnosis. Often people with OCD have all three. When I treat people with anxiety, they often have anxiety and depression. When I treat people with depression, they often have depression and anxiety because those, and we need to treat both. I know that a lot of times people go into the hospital settings or to their doctors and they get treated with depression, but they never get treated for the underlying anxiety. Yeah. And what happens is they get treated with the depression, they get that kind of under control, but the anxiety has not been touched. So we really need to teach people to be able to learn, to be able to overcome both together, and the OCD as well.
Well, Sandra, this is kind of like just a side question here, but would this be connected to any eating disorders? Like the anxiety and the control are definitely eating disorders. Yes. So is OCD connected in there as well?
Yes, and it's interesting because on my I have a website. It's www.theocdcoach.com, and on there I have a podcast that AJ, a good friend of mine that I became friends with through Life on Fire Academy, I interview her on her eating disorder, and it's all about control. And we have what we call spectrums on the disorders. So often eating disorder, OCD, can be often go hand in hand. Body dysmorphic, body images, having a view of our body being distorted. So people will focus on that. But all of those disorders in some way have a way of trying to control. So controlling what we eat, controlling what we look like, controlling catastrophic events from happening in the realm of OCD, right, to ourselves or others. So yes, absolutely. There can be a lot on the spectrum of OCD.
So there is overlap there.
Mm-hmm. Yeah.
So, and it sounds just the way you're describing, you are treating OCD a little bit differently than some of the other clinicians.
Well, yeah, I can't speak for the other clinicians, but I know that there's a lot of people out there that say, I remember when I got diagnosed, before I got diagnosed properly, they had a kind of I went to see one doctor and they said, you know what, it's OCD. It sounds like OCD. I'm not sure. But what you need to do is wear an elastic band around your wrist. And every time you have a bad intrusive thought, pull on that elastic band and the thought will go away. Now, most of us ladies can appreciate when we put our hair up in a bun or a ponytail, the elastic loses its elasticity very quickly if you're pulling on it all the time. So the intent, the message there was for me to pull on it. So I'm concentrating on the spring back of the elastic versus my thought. That never worked, because until you deal with the core of it and change, it's a pivotal shift in our mind. Until we deal with that and we're able to change our cognition, nothing else will change. 20% medication touches 20% of overcoming OCD. The other remaining 80%, we rely on our behavior. So we really need to change the behavior, because as I mentioned earlier, and I didn't finish this story, Linda, was our neurotransmitters, as I said, are firing off false messages. It's like having the gas and the brake on at the same time, or a hiccup in the brain. Our obsessions are going over and over, and our neurotransmitters are not messaging properly between what we call the pre and the postsynaptic cleft. There's the serotonin, which is a neurotransmitter, a chemical in the brain, that's being affected with OCD, but it's also being affected with anxiety and depression. So we can treat all three with medication to some degree, but the rest, we really do need to address the behavior, behavior. Otherwise, we're just doing a Band-Aid fix to some degree. So we have to get to the root.
Yeah, break the cycle of the repeat. So Sandra, what would you say to encourage anyone who's listening who might recognize some of these behaviors?
When it comes to any of them, is to really reach out to someone and do your homework, because, you know, some of us get so scared when it comes to reaching out for help. We feel that the person on the receiving end of getting the questions is going to not appreciate us asking the questions, not want us to explore further in depth how they can help us. But you need to take control of your own life. It is your life. So you need to be the best advocator and the best cheerleader for yourself. So when you're reaching out, ask the person that you're reaching out to, what do you do to treat OCD? What do you do to treat anxiety? What do you do to treat depression? If it's just a matter of doing medication or, you know, things that aren't diving in deeper and it's all on a superficial level, then you owe it to yourself to go somewhere else and get the expertise that you so rightly deserve. Because a lot of people have been living a quiet life of desperation for far too long. And that's my mission for the rest of my life, because God gave me the OCD, and God also gave me the opportunity to go and serve others. So make sure that you work with people that are in the know, because those are the people that are going to help fast track you to get results if they got the specialty behind OCD, anxiety, and or depression.
Yeah. Yeah. Like you said, people are fearful of a diagnosis or a label, but have value and deserve to have a life that they can enjoy.
Yes, yeah. And it's all about living a life that matters. Like, I worked with one young gentleman. He was confined to his bedroom, and he hadn't been out of his bedroom in almost 8 months. And they would slip the food under the doorway and he would slip it back. He would urinate and he would have bowel movements in his bedroom. They put up a little container. I mean, this fella was confined to the four walls of his bedroom. And I could relate, because there was a time where I was confined to my apartment. I wasn't even able to go down 3 stairs to the lobby of my apartment block to get my mail, because I was so terrified. So this can be a very, very debilitating disorder, to the point where you can't even leave your home. So I don't treat it lightly. I make sure that I do thorough assessments when I'm meeting with people. And the other thing is to know what questions to ask, because people are not going to voluntarily offer these thoughts that they have. Because like I always said, these are my thoughts. Like, how could I share them with the outside world? There's so much shame and guilt associated with these thoughts. What will people think of me? I've had people ask me to admit them into psychiatric hospitals because they feel that they're pedophiles, or because that they're going to kill their loved ones. And I refuse to do that based on my assessment, because I know very strongly that they are not that type of person. And that's why it's so disturbing, Linda, is because we don't want to have those thoughts. They're unwanted and intrusive. Remember when I said back to the beginning, we do not want to have the thoughts. So we question our morals, we question our ethical beliefs, when in fact it's all to do with OCD, and it's not who we are. So as a coach, I always learn to separate those two entities. OCD and us, we're two separate entities.
Okay, well, thank you for your information. And you've written a book as well, Sandra.
Yeah, I wrote a book. I wrote a book called Stop Obsessing and Start Overcoming. OCD Leaves Clues. And it's on Amazon. It's available on Kindle. We're just working on getting a paperback up and running. So if people are interested, they could go on and be able to purchase that Kindle. Now, Kindle is something that anyone can buy it. You don't have to have a Kindle for it. And my next book, we are taking pre-orders. It's called 6 Secrets to the Deliverance from OCD. And it's a really in-depth dive in for both people living with OCD, family members, loved ones, and professionals. And that should be out, I'm hoping, by the end of February, early March, available as well.
Good for you, Sandra. We're going to have a link available to link people to the book, and also in the resource section within the Facebook group as well.
Okay.
And also a website link to your website. So
okay, great.
That's
great.
Thank you so much, Sandra. You've given us a lot to think about. And I'm sure, like, the more knowledge we have, the more compassion that and empathy
Mm-hmm.
we are able
Yes.
to give to other
Yes.
people. So
That's
that's
right.
always important too.
Yeah.
Um, and I just appreciate your time today and just all the yeah, just your sharing your story personally, that
Thank you.
is able to help so many others.
Thank you. And
So
as a offer too, I'd like to for anyone listening, if they're listening and they're thinking, well, maybe I have anxiety disorder, maybe I have OCD, maybe I have depression, maybe I have all three, because I've had all three at some point in my life. I'd like to offer a free 15-minute consult too. So feel free to go on the website and we can make a connection and look a little bit, dive a little bit deeper into it, Linda. So,
that's great. That's
okay.
great. That's a good offer. Yeah. Thank you so much, Sandra. And we'll certainly look forward to hearing more about your book, your upcoming book, and you can share the link with us when it's published. Thank you.
Okay, I'll do that. Thanks so much.
Okay, and thank you everyone for joining us today, and we'll see you next time. Bye bye for now.